and any thoughts that you have in your treatment approach with these patients, whether etiology makes a difference in your treatment approach, for example, biomechanical trauma versus infectious origin.
Oh, I don't doubt that etiology makes a difference, but for the great majority of these patients, I have yet to learn any reliable patterns as to which particular drugs or even which particular classes of drugs are most likely going to help any one of those patients. Um, so, you obviously want drugs that'll penetrate it. You prefer drugs that'll penetrate into the central nervous system, but fortunately, most of the drugs we use for this disease do accomplish that. Not all of them, but most of them do. The pain, it's it's probably coming mostly from the mast cells from various mediators being released by maybe peripheral mast cells, but more likely central mast cells. Then various inflammatory mediators hitting on pain sensing neurons, whether peripheral or central, and it causes pain. Um, so I mean, if there are other treatments out there for addressing pain, other than narcotics, obviously getting into a situation of narcotic addiction is not good, especially since narcotics pretty much all are mast cell activators. Some are much more egregious than others, but to one degree or another, virtually all opioids are triggers of mast cell activation. So we try to avoid those drugs as much as we can. Sometimes you don't have a choice. But if other manners of pain control are not working and you can define MCAS in that patient, then perfectly legitimate to try all sorts of different mast cell targeted treatment. I've seen patients who have had nonstop migraines for a quarter century and failed every classic migraine treatment imaginable. And then we figure out they've got MCAS, and it's sometimes, I kid you not, it's nothing but an H1 blocker or an H2 blocker or the combination of them that completely shuts down the migraines. And other drugs too that can help with pain. We talked about the deep bone pain and how low dose hydroxyurea can often be helpful with that. It's interesting because what's the other situation where you chronically use hydroxyurea? It's sickle cell anemia, and all those patients have bone pain. And we used to think it was the vaso-occlusion that was doing it, but actually research in the last dozen years has shown pretty clearly, nope, it's not the vaso-occlusion causing the bone pain in sickle cell. It's actually mast cell activation that's causing the bone pain in sickle cell. And we were all taught that hydroxyurea helps in sickle cell because it increases hemoglobin F, fetal hemoglobin production, and therefore you kind of automatically get a decrease in sickle hemoglobin production. But if you actually look at the data on that, the amount by which fetal hemoglobin production is increased by hydroxyurea is trivial. And it can't possibly account for why these sicklers are chronically taking hydroxyurea and seeing so much of a reduction in their crises and their bone pain. And you start to realize, and furthermore, one other key piece here, if you take care of enough sickle cell anemia patients, you realize that about 85% of those patients have pretty mild forms of the disease, mild crises. Very occasionally, they take some modest pain drugs for 2 or 3 days, and that's it. The crisis is over. But then there's the other 15-20% of sickle cell patients. And keep in mind, all sickle cell patients have exactly the same mutation in beta globin, but there's 15 to 20% of them that are horrifically severe patients. They're always having crises, always in the ER, always bone pain that takes 3 weeks to get over. And you say, what's different about what if they've all got the same mutation? What's different about those 15 to 20%? And I published a paper about, I don't know, a dozen years ago that showed pretty much every single one of these bad sicklers, they've got MCAS. And you can actually transform a high resource consuming bad sickler into a low resource consuming good sickler just by getting the mast cell disease under better control. But when you start to put all these pieces together, you start to realize that maybe the reason hydroxyurea is working in sickle cell disease is because it's actually addressing MCAS in those patients. There's something about the drug that settles down the mast cells in a fashion where they're no longer releasing mediators that are driving bone pain. So I uh, so over the years I picked up these few tiny hints about which drugs might make sense to try sooner rather than later in various MCAS patients for various symptoms, whether it's pain, as you asked about, or any other symptom. But I'll be the first to acknowledge this is far more uh, trial and error. It's far more clinical art and experience on the part of the managing clinician, much more so than any amount of already published or established clinical science or research that's going to determine the particular sequence by which we go trying these many different drugs in the individual mast cell patient. And again, don't go thinking for a moment that the cost of the drug is going to augur response. Plenty of expensive things that are tried in these patients utterly fail. So unless I've got an awfully good reason for trying an expensive treatment sooner rather than later, then I tend to start with the cheap stuff and I escalate in expense as needed.